my talk will be on the management of pythium keratitis way forward. Um, Pythium keratitis, recently it has gained so much of attention from everybody because of increasing reports, and it has been recognized as a disease, infectious disease with high morbidity and mortality. In the past, PIMSHEEM in 1858 has recognized genus Pythium as true fungi belonging to eukaryotes with a filamentous non-septate morphology without cross walls. Since their nutrition was by absorption and reproduction was by spores, they were classified as fungus. But in the present, it has been recognized as belonging to a protozoan oomycete, and the cell walls contain cellulose, beta glucans, and hydroxyproline. Hence, they are resistant to antifungals. Pythium insidiosum, it is the only species to cause infection in mammals, and the first report of keratitis was in 1993 in a 31-year-old woman from Thailand with a sickle cell trait. Till 2021, there were only 168 oculopythiosis reported. Maybe the sparse reports on this pythiosis maybe is due to the lack of awareness about the microscopic and colony morphology, lack of high clinical suspicion from ophthalmologist side. The risk factors associated in the past, it was thalassemia and sickle cell traits and swimming with the contact lenses and contact with farm animals and swampy areas. But in the present, even we find homemakers and IT professionals to acquire pythium infections. And motile zoosperms, they are the infective agent. Whenever they are attracted to the open wound in the skin, the zoospores insist and they secrete glycoproteins, and this causes tight contact with the host and cause release of inflammatory mediators and granuloma formation and extensive tissue damage, and both in humans and animals. Clinical features of pythium keratitis include they cause mostly subepithelial superficial stromal infiltrates with the tentacle extensions and maybe a reticular pattern and dot infiltrates. In more advanced cases, they have a typical peripheral furrowing. All these pictures are very much similar to the fungal keratitis, but the thing that I learned like from the cases I have seen, since 2016 we have seen around 25 to 30 cases of pythium only, but the clinical diagnosis was much more faster than like getting the culture identification. It's better like if we just see and record like in our memories, then the picture of the pythium keratitis, it would be easier for our patients to get diagnosed much earlier. The direct microscopic examination on cursory look may resemble a fungal filament, but the pythium filaments appear much broader and ribbon shaped with the right angled branches. So this typical appearance also has to be like taken care of, and we have to like make the microbiologist aware of this type of appearance of the pythium filaments. And zoospore formation from the SDA is the confirmatory test, but it takes around 5 to 7 days, and it is only 79 to 96% sensitive. So the successful management of pythium keratitis depends upon the early diagnosis of the organism. So that needs many diagnostic modalities like a matrix assisted laser desorption ionization time of light mass spectrometry is one such diagnostic modality which identifies the pythium keratitis very rapidly and accurately, and there is a species specific identification done accurately with this spectrometry. It doesn't require any antigen, antibody or the primer. And as ma'am was insisting on like confocal microscopy, expert clinician who is very much like familiar with this clinical pictures of the confocal pictures of pythium keratitis can easily distinguish it from the fungal filaments. So these pythium filaments, they appear as a beaded multiple string-like hyper-reflective branches, and the branching intersecting angles will be at 78.6 degrees, and width is 4 millimeters and micrometers, and length is 350 micrometers. So this modality is 94% sensitive, and the experience, the expertise can definitely distinguish this filament from the fungal filaments for early diagnosis. In case of high clinical intuition, as I said earlier, clinical diagnosis like early suspicion would be better, like in such cases to have a early diagnosis. And PCRs are gold standards, and they help in species specific identification of the DNA portions, and from even from the corneal scrapings or from the sample from the agar plates also. So another this is not newer one, but the extension, like we can make use of all these previously available diagnostic modalities like thermophilic helicase DNA amplification using the primers, and they are also rapid and accurate. Most important, like a very interesting thing was Mittal et al. In 2017. He has put forward a staining method which is already existing, but he combined with the gomerin methanamine silver stain with potassium iodide and sulfuric acid stain. So he has used this stain for staining the oomycete, and he has confirmed that it is 100% specific and sensitive in identifying the pythium. And Zhang et al. In 2021 had done some studies with the animal antibodies with the indirect immunofluorescence assay to find out accurate diagnosis of Pythium keratitis. So management in the past, as we all know, we all have this experience because the diagnosis was delayed, the management was also delayed in this Pythium keratitis, hence 90% of them ended up with evisceration and enucleation. But now, because of the increased awareness and improved understanding on the pathogenesis and the better understanding of the evolutionary associations and faster diagnosis, and we all know now that the Pythium insidiosum is susceptible to antibacterial agents and instead of antifungals. So the evisceration rate definitely reduced to 15% from 90% now. And the antibacterial agents that are being reported in literature sensitive to for Pythium keratitis are tigecycline, azithromycin, tetracyclines, linezolide, minocycline, chloramphenicol, and clarithromycin. New antifungals are under trial. They are found to have some synergetic effect against Pythium isolates in vitro. So Bharat Kurgani et al. Had proposed a treatment algorithm for managing Pythium keratitis for both culture positive and culture negative cases based upon the size of the ulcers. For patients with culture positive Pythium, based upon the size of the ulcer, the monotherapy of linezolide or linezolide with azithromycin was prescribed, and for culture negative patients, all were treated as a fungal keratitis, and they, depending upon the size, they were also started on antifungal agents, either natamycin, itraconazole, or oriconazole. The take-home message of this algorithm is that whenever there is a poor response to the medical therapy, go for an early TPK, and in culture negative cases, after TPK, the button would be sent for culture, and if Pythium is positive, then continue treatment accordingly. This is one of our patient who had he was an IT professional with a circumferential peripheral corneal infiltrate. It was superficial stromal with a tentacle like extensions and dot infiltrates. Because the visual axis was clear, the patient was not willing for getting admitted in the ward, and because of the clinical suspicion, before we could get the culture positive, we started on linezolide, and the smear microscopic smear also came positive of fungal filaments. So we added natamycin also along with it. But after 5 days, he came with a total corneal ulcer, and we had to do an urgent keratoplasty with a larger graft, and we continued with linezolide, and that time the culture came positive for Pythium, And then we continued with linezolid and azithromycin, and oral azithromycin was given for 2 weeks, and patient responded well, but the infection subsided only after 1.5 months. This is another patient, a 60-year-old farmer, who presented at this stage of near total corneal ulcer, very superficial lesion, and with the typical the tentacle extensions on the periphery and the dot infiltrates. There was a peripheral furrowing too in this case, which typically we identified clinically. We diagnosed this case, and the microscopy and the culture was also negative. Then we did a therapeutic keratoplasty early, and the culture of the button revealed a pythium, but the patient he presented after 7 days with such like the graft infiltrate, and the infection was spreading to the sclera and the vitreous also. So we had to do an evisceration for this patient. Bhupesh Baga et al. had reported a comparative series of 208 cases on successful management of pythium keratitis. He has compared two patients in 2 timelines, and out of 96 cases who were treated with the pythium positive cases treated with antifungal agents between 2014 and 16 with antifungal, 90% required TPK, and it reduced to 46.4% when treated with antibacterial therapy during 2016 to 2018. So the early diagnosis and early initiation and early surgical intervention, if the medical therapy fails or if limbus is involved, adding a surgical adjunct therapy is more important. So TPK is indicated for patients with pythium, proven pythium keratitis of more than 4 mm size, and aim for a larger graft with 1 mm clear host margins. And adjunct therapy if the limbus is involved, like cryotherapy to the host margins, and also ethanol dip swab to the host margins while doing keratoplasty has definitely reduced the risk of recurrence in these cases. The photodynamic therapy and the immunotherapy with the PI antigens, they are only for refractory cases of pythium insidiosum. Pythium insidiosum antigens like vaccines are available. They are more efficient and proven to be efficient for systemic pythiosis, but for ocular pythiosis this vaccine has not been proven, but it needs larger validation in future. And many experimental studies are going on to extend the usage of other group of antibacterial agents, anti-leishmanial agents like miltefosine for pythium keratitis, even substances like biogenic silver nanoparticles, copper acetate, and natural extracts like a coumarin derivative from a green plant xanthillitin. The studies are going on for the pythium. So now many the clinical literature evidences are existing to prove that the extensive damage that occurs in pythium keratitis are due to the release of the inflammatory mediators. So these inflammatory mediators like T helper subset of inflammatory reaction, they are composed of eosinophils and mast cells. These cells degranulate and they form a splendor hopefully like a granulomatous reaction in the tissue, and this is believed to cause the extensive tissue damage. So based on this, whether we have to tackle the inflammation or the infective agent as such, that we have to decide in future. Based on this, whether is there any role for a cyclosporin or a tacrolimus in early pythium keratitis and C3R? Maybe it's a question. It's open for discussion for future. Thank you.
Yeah.
I have a question for all the panelists. I have treated a number of cases of pythium keratitis. I have not been successful in preventing the keratoplasty for a single patient, whatever be the size of the lesion. I have tried linezolid, azithromycin, I have tried voriconazole, PHMB, but finally I've always had to go for a keratoplasty. What's your personal experience?
Most of the cases we have done only keratoplasty, and few patients had healed with linezolid. Very young patients who were not homemakers. We saw 1 or 2 females but a few candidates like 38 years old, 35, that age group, they healed well with linezolid alone monotherapy, and most of them required therapeutic keratoplasty, and recurrence was the major drawback.
You were comfortable with both linezolid and azithromycin
yeah,
for those
one
patients?
case I added a minocycline also. That was costlier, and patient was affording to it, but the infection did not get controlled in that. I don't know why.
How long did it take you to achieve a good outcome?
Ma'am, it did not we did not get a good outcome out of
Okay.
adding a minocycline.
A few things, Anita. I think that was a fantastic enumeration on your experiences of managing pythium keratitis. So, just for the benefit of our audience staying here, so we do, I think currently we find that topical azithromycin works well and linezolid works well. So, azithromycin in the currently commercial percentages works well, or do you reconstitute it? That's one. And how do you go about preparing linezolid drops for management of these cases?
Ma'am, linezolid drops we manage from the tablets we get from the it is available for a systemic usage from the tablets, and azithromycin we don't reconstitute, ma'am. We directly use it from the
Okay.
prepared.
And what would you recommend when you have a clinical suspicion, a high suspicion of pythium, say you do not have access to microbial diagnosis, then what would be your typical modality of frequency of drops? Would you prefer to start linezolid, or would you use a combination of linezolid with azithromycin on a case of clinical suspicion?
Like if the ulcer is maybe this depends upon the size of the ulcer also. Like if the ulcer size is less than 4 mm, maybe we can start with. I have started with the whichever cases I told like good outcomes were treated only with linezolid drops. We didn't even add oral azithromycin there, but because the ulcer size was smaller. And larger the size of the ulcer, it's better that we combine with azithromycin and oral azithromycin also.
So one thing,
Yeah.
yeah, one thing that you can do as a suggestion is to send a specimen for corneal biopsy. So because you are deviating from the protocol of infectious keratitis by adding a newer modalities. So subject to that newer therapy, you need to send your patient's sample, a deeper corneal biopsy or a suture biopsy. So they have a higher sample positivity that can come, or subject your patient to confocal microscopy. So PCR is a very rapid test, and that can be also very sensitive in picking up pythium. It doesn't matter if it's new or old. So we have some experience. Topical linezolid, you can just take it as a parenteral preparation and put it in the amber colored bottles, and ask the patient to buy a new linezolid every 2 to 3 days, and do not allow it to become darken in color. And it can be safely combined with the topical azithromycin. So there are reports of combining these two agents very uniquely. One was a group which actually gave parenteral linezolid and topical azithromycin.
Okay.
So that was from the LV Prasad group, and GMR we published this data. So that was a very interesting article. The second thing that you can do is hike up the dose of oral azithromycin from 500 milligram to 1 gram. So that also is one of the suggestions given.
And how long would you, sorry, how long would you wait?
So this is a very slowly regressing disease with susceptibility cause thinning and perforation. So you have to keep the patient at least on 6 weeks of topical linezolid, and the oral azithromycin is suggested that you give it for 2 weeks, and you actually, it's a macrolide which gets it gets accumulated in the body. So you need to test the patients for ECG to make sure that there are no QT intervals which are prolonged. So before you give the patient oral azithromycin, QT intervals has to be checked. Otherwise, the patient can have a cardiac event.
Yes.
Ma'am, with azithromycin, the recommended systemic dose is about
500 milligram OD.
1.5 gram maximum dose, even over
Yes.
3 days. So 6 weeks it would accumulate in the liver, ma'am, actually.
This 6 weeks is for topical therapy.
Oh, topical
Yes,
therapy.
2
Okay,
to
ma'am.
3 weeks is for oral therapy.
Yes,
Yes,
no,
and
2 to
then
3
you
weeks oral what
Even a
dosage?
very high
that is
Yeah,
systemic
yes,
toxicity
yeah, we would keep the patient under a physician care and
Yeah,
liver function
absolutely,
test. Most
liver
important
function,
is to
yes.
see the ECG.
Okay, ma'am. Because that is really high, ma'am.
Not to be recommended for older patients.
Yeah, these are all younger patients, so they did well actually.
Okay.
So I had a postpartum pregnant lady who came. So she actually had the clearance from her gynecologist to take oral azithromycin for 2 weeks. So we stopped breastfeeding for her and allowed her
500
500 milligrams.
for
Because she had
2
very
weeks.
severe itchy. Yes, yes. You take the opinion of your physician
Yeah,
when in
yeah.
doubt. You don't have to do it in
Yeah, this is high.
seclusion.
Nice.
500 milligrams every day for 2 weeks.
Yes.
Yeah.
Earlier there was a recommendation that was like twice a week. Remember the first paper that came with topical azithromycin was twice a week for this. Yeah.
Bhupesh regularly gives 500 milligrams.
Ma'am, what were the fundus findings or whether ultrasounds has been done for these patients? Because so much anti-segment inflammation, there must be something in the vitreous, or whether the combined surgery, TPK plus vitrectomy, has been done for such cases.
I don't.
I
sorry.
mean, whether the
So much of inflammation.
Speak a little louder, you're not
ma'am, I am asking whether the ultrasound findings were something in the posterior segment inflammation or these things, or
What he's asking is if there's associated anterior vitritis or the evidence of endophthalmitis
Yeah,
associated
exactly,
with
ma'am.
severe keratitis
yeah,
presentation of cases of pythium, right?
yeah,
Yeah.
ma'am.
So how?
So I am
your
asking, you have done TPK, whether this surgery has been combined with vitrectomy or only TPK has been done?
Only
Okay.
TPK. Only TPK with just a TPK. We didn't do with cryotherapy. We have combined, but we didn't do
Combined vitrectomy.
vitrectomy was not done.
Yeah, I think most of the protocols for surgical interventions, therapeutic interventions for transplantation, we would avoid doing a posterior segment surgical intervention when your lens is clear or when you do not want to remove your lens. We would prefer only to do an anterior intervention. Only if your lens is extruded and you perhaps do not have a choice would you go in and do it. That said, I think it's a protocol for almost management of almost all kinds of severe keratitis.
Thank you.
But cryotherapy can be combined. So that
That's a
that is
very
of
good,
very
yeah.
good use.
Is there any study that it is prevalent in some parts of India and other places it is not? Is there any study till date that this particular fungal infection is prevalent in some parts of India?
Like most common in tropical and subtropical areas, it has been reported. India, it has been reported in, I think in all states we have cases being reported from Andhra also, from Tamil Nadu and from Maharashtra. Like
So I'll just take that question. So, sir, answering your question, these patients have filamentous KOH positive filaments, but unfortunately on the culture, they do not produce any spores. So the microbiologist gives a report as non-sporulating mold. You have to take that one step ahead and get PCR DNA sequencing, and that will be bang on target and tell you that this is Pythium insidiosum. But before you do that, you become familiar with the clinical features, which are very, very specific, in fact, for Pythium insidiosum.
One of the things that happens with Pythium is that the clinical picture is flat, white, but it grows very quickly. It does not sporulate. That is why it goes as unidentified. But over a period of time, the clinicians as well as the microbiologists have got together to understand that you see the clinical picture, what you see, was dense plaque-like lesions, the dot-like lesion. You flag off the microbiologist and say that I'm thinking Pythium. So they take a look again at the smear. And then when you the minute you get the blood agar plate growing, you immediately start doing the zoospore formation.